I'm Glenn Wood.
And I'm Richard Tademir.
We're psychotherapists based out of British Columbia, Canada, and you're listening to Deliberating Practice.
In this podcast, we deconstruct everything from the foundations of therapy to its newest innovations and horizons.
We take a critical perspective on contemporary issues that affect therapists across the world. We share our own stories, both personal and professional, and sometimes we talk to other therapists too.
We hope that this podcast can be like sitting with the trusted mentor you always wish you had, helping you integrate and make sense of our complex and exciting field.
So sit back, relax, and enjoy the episode. For resources, show notes, and to work with Richard or Glenn for supervision, consulting, or counseling, go to deliberatingpractice.com.
Hey, Glenn. How are you doing tonight?
Hey, Richard. I'm doing good. How are you doing tonight?
Oh, I'm excited to get into the controversy and ride the dodo bird.
Me too, Richard. We have a really exciting and fun episode planned for our listeners tonight. Why don't we each take a little stab at figuring out what we're talking about tonight?
Yeah. So we're going to talk a little bit about Wampold's contextual model. And there's a wonderful podcast with Bruce Wompold and Jonathan Shedler. And what stood out to you, Glenn, or what more do you want to say about that?
Yeah, I sort of feel like tonight's episode might be the first in a series of episodes where we provide critical commentary on what is known as the great psychotherapy debate. So we have alluded in other episodes to this debate, which rages on ever more into our contemporary era, about which psychotherapy is best, about the different modalities and their relative effectiveness. So tonight's episode is really meant to be sort of a deeper dive into two players in that debate, Bruce Wompold and Jonathan Shedler. Bruce Wompold being a researcher, a psychotherapy researcher, and the developer of the contextual model, sort of common factors psychotherapy, and Jonathan Shedler being a psychoanalyst, psychodynamic therapist, a psychology researcher that's really focused on the psychodynamic frame and has a very strong critical position on how contemporary psychotherapy research is done. So we're going to be looking at a debate that they had, or maybe not a debate, but Bruce Wompold has his own, I think it's called the Making Therapy Better podcast. And so he's a big name and he gets big names on his podcast, lucky guy. And so he had Jonathan Shedler on, I think 8 or 10 months ago. They released an episode where Shedler was really able to talk about some of the specific criticisms he has about psychotherapy research, and Wampold provided some commentary and critique and some of his own position in that. So we're going to spend some time looking at that because I think there's important implications in Shedler's arguments and position, and in Wampold's as well. He says some important things and there's some agreement amongst them, which we'll talk about and illustrate some of the important problems in our contemporary era, which is what you and I are all about. Isn't that right, Richard?
We're all about the controversy.
That's right. That's right. Why don't we start by introducing Bruce Wompold, because he sort of forms the basis of this. He's maybe the structure or represents the structure in a way that Shedler's trying to be critical of. Richard, do you want to say a little bit about Bruce and the contextual model?
A little bit. Yes, as Glenn mentioned, well known for this idea of common factors, the common factors model or common factors approach. I guess the argument is that therapies do not differ too much, almost to an insignificant or statistically, insignificant amount between each other, maybe something like 8%, of the contribution of change. But what really matters is the relationship. And I think, sure, we would all agree with that. And I think when common factors came out, it was, a pretty exciting, being the old guy here, Glenn, I guess old, at least in terms of psychotherapy, though we're not that different in age. It was the hot new kid on the block, I guess, in the sense of challenging a lot of what was really happening in vogue was CBT was the best. I can remember this as I went to graduate school, undergrad in the early 2000s, and then undergraduate school kind of in the 10s or graduate school in 2010s, that CBT was really being argued as this is the thing. It can be easily manualized. It's more effective. We all just need to be doing this. And so when common factors came out, it was a big shock to the system, kind of a paradigm shift or a scientific revolution in a sense of, okay, hold on, like hold your brakes. Maybe CBT is fine, but also so is humanistic, so is existential, so is all of these other ones, right? But what we really need to focus on is a relationship. And I think for many years that common factors has become more and more common. We also have talked about, slightly different, but into areas of like some of the micro skills that are common across different methods. So whether you're practicing existential, whether you're practicing humanistic or psychodynamic, oh, we're going to look at you as the practicum student about what kind of micro skills are they using. So kind of this idea that all these therapies are kind of the same and interchangeable. But there are some big problems with that we've been seeing in recent years, or at least those in a critical psychology, depth focused paradigm are seeing that are challenging some of these assumptions. I'd love for you to talk more about that.
Yeah, sort of later, I think, as we get into Shedler, but I sort of want to expand upon something that you just said, Richard. There's an image coming to my mind, or just a metaphor for the diversity in the psychotherapy space, which I think the common factors researchers have done really, really well. Kind of all recognized that the fact that there's different labels and different stances in these psychotherapy modalities, that they're kind of all just cola, different brands of cola, right? And we like them all because they all have sugar and carbonation and, maybe in different quantities, maybe to a different degree a little bit. But factors, folks, they really care about these essential ingredients that make this therapy effective. They're less concerned about the brand name. They're less concerned about the labeling, whether it's sold in a 6-pack or a 12-pack, those things. They just sort of are asking the question, what makes the cola that is psychotherapy tasty, right? And I think that that's what Wampold's speaking from, isn't he? He was one of those researchers that really saw that, saw what was emerging in the world of research, saw the dodo bird effect research kind of demonstrating relative equivalency amongst the therapies, and went, okay, well, this is important. This says that this emphasis on difference is the wrong way of looking at it. We need to be looking at the commonalities. We need to be looking at what we're all doing good, right? And I think that's kind of a commendable position that Wampold has taken. I got to say, I actually like Bruce Wompold a lot and what he's doing. I think that he's solving an important problem, because it doesn't help us, I don't think, to stay in the campiness that has been psychotherapy schools of thought. Although there's a caveat to that, but I promise we're going to dissect this as time goes on in this episode. But I think what Wampold is doing, what the common factors researchers are doing, is helpful. It solves that problem, at least. It's no good when we're at war with each other and when we're campy about our therapeutic modalities.
Kind of making therapy more trans-theoretical, trans-diagnostic. What are these mechanisms that are common across therapy that implement change?
And trying to cut through the fat. What doesn't matter and what does? What ultimately accounts for effectiveness and what doesn't? And so Wampold bases his contextual model off of trans-theoretical effectiveness research, the sort of multifactorial analysis of psychotherapy, research coming out of the common factors, looking at what accounts for real change. But I think the contextual model, at least from reading Wampold's work, is meant to be a little bit different. He's not just highlighting common factors that are sort of common to therapeutic effectiveness across models. He's trying to develop a model of itself based on those factors. So he's saying, okay, I've sort of looked at all of these, I've condensed them into specific sort of pathways, specific sort of factors. And this is where I'm going to start my construction of what psychotherapy is and how to make it effective, is sort of from this place. So I'm not just trying to name them. I'm actually trying to build a model that can help guide our thinking about therapy. This is where to look. If we want to ask the question, how do we make therapy effective? This is where to look, right? And what extends out of this model is, Wampold says, we don't need to be so situated in this or that theory. There are sort of 3 pathways to change that psychotherapy acts upon. And maybe, Richard, you can take it away and describe the 3 pathways as you understand them.
Yeah, happy to. The first part of the pathway is the real relationship. So relationships provide an important foundation for positive therapeutic effect. It's the second most important factor after client factors. It's therapeutic in itself to a degree, and it's necessary for therapy, but it's not sufficient. So sometimes we call that alliance. We call that certainly the therapeutic relationship.
You have to like your counselor. They have to be nice
Yeah,
to you.
it can include a lot. I love
Yeah.
that you mentioned that.
Yeah.
It can include what we believe is in common between the therapist and the client.
Mm-hmm.
It can include, as kind of Scott Miller talks about in feedback informed treatment, and he would kind of take the argument that anything that builds the real relationship or alliance is the number one thing and what really matters and differentiates a highly effective therapist between a less effective therapist. So all of his measures, like the session rating scale, etc., pertain to that idea. And then we'll talk about expectancy effects, the second in the three pathways. This is, I'll read some of this directly here, and then we can explain the specific modalities explanation of the cause of the problem and the solution to its amelioration is less important than the client's faith or belief in the modality and their expectation of its effectiveness. In other words, it's an explanation for the disorder. So why is the person struggling? Why do you have nightmares at night? And the actions that would be essential. A common factors therapy that doesn't operate under a working model of suffering and its alleviation can only be effective through the relational pathway. The therapist too needs faith, a clear vision for what will be effective. When I was reading this article, it gave me this idea of the therapist maybe using metaphors that are familiar to the client. It might be using language familiar to the client. It is giving an explanation. Many years ago, our explanation for why a person was having, we wouldn't even have used those terms back then. The ancient Greeks talked about humors, right? Your humors were misbalanced, right? So they would needed to go in there and bleed you out or give you some magical potions to balance those humors again. So that was an ancient Greek world kind of explanation that would have been very relative to the patients of Socrates or Plato back then. Nowadays, we would have some therapeutic model, probably from a school of therapy explanation. So cognitive behavioral therapy, like its explanation would be you have these cognitive biases. Basically, you're not thinking right, so to speak. And by figuring out what these biases are and kind of challenging them, stopping yourself and challenging them every time, you will get freedom from these symptoms.
So Wampold is really saying what matters is that there is an explanation for what's going on for the patient that the patient finds agreeable.
And that they understand.
That they find agreeable, and that they have some faith in. And so
they bought into it.
Yeah, as long as it sort of satisfies them and they have a sense of faith or expectation that the therapy will be effective, the research shows it is. The research shows that it actually doesn't really matter what the explanation is in many respects, that there can be a wide variety of explanations for the problem and its solution. What's more important, and this is kind of interesting research, this is almost worth breaking down and talking about in and of itself, but what's more important is the client's faith in and sort of agreeableness to the explanation and their expectancy that the therapy will be effective. And then I had a note in there too about it also being important for the therapist. Wampold kind of pointed out that the therapist also needs to ground themselves in a model. So even though his research, or sort of the research he's basing this on, shows that there isn't really a model that is more or less effective, what is ultimately important is that a therapist choose a model and ground himself in a model nonetheless. Because if there isn't a model that creates this expectancy effect, then the only way the therapy can be effective is at the relational level. If you're just relying upon common factors without, sort of structuring your therapy around some sort of, or maybe not even structuring, but at least basing your position relative to the client and your assessment and your interventions, the work that you do in the room around some model of suffering, you won't create this particular pathway of effectiveness. You'll just be confined to whether or not the patient likes you. And Wampold's assessment is that's important, but that doesn't actually carry a person all the way to change.
Whether they like you, whether they kind of want to perform,
whether there's a good
you,
relationship,
you have influence, lots of things. That makes sense. The third pathway is or element of the pathway is the enactment of health promoting behaviors. So Wampold argues that all therapies ultimately encourage or support patients in engaging in some type of behavior that is health promoting. While most therapies privilege a certain domain, like relationships, cognitions, behaviors, the self-relationship, improvements in one domain often lead to improvements in others. Ultimately, therapies work because they ask people to do something that results in health.
Yeah.
Anything you want to say on that? Yeah.
I think just reiterating what you just said there, Richard, because that was really good. Wampold is saying that the third pathway is that most therapies will ask people to sort of do something that ultimately has some association or connection to health. So whether that's just communicating their feelings to sort of structured behavior interventions, therapies evoke a wide variety of interventions that ultimately get people engaged in something that promotes health. So again, Wampold's not so concerned about what the intervention is necessarily. He's more concerned about the fact that therapeutic interventions tend to focus on something that, has some benefit to the client, right? Whether it gets them
action.
Yeah, it gets them exercising more or communicating more with their loved ones or thinking differently. And he's sort of saying that there's a compounding effect, or that an improvement in one domain often has a trickle effect into other domains. So even if you're just working on one domain, you tend to see benefits outside of that domain as well.
Like, for example, if you're challenging your social anxiety by now having 30-second conversations with strangers, you also may be improving your overall level of anxiety in other domains.
Yeah, that's right. That activity in and of itself might build some confidence, and that confidence then carries you forward into other.
You may feel less anxious, so to speak. Yeah. Okay.
Yeah. I like that. Yeah. So that's sort of our basic understanding of the contextual model and where Bruce Wompold is coming from. So he's a common factors researcher. He's developed a model that's sort of non-specific, but is sort of meant to be a starting place for our analysis and construction of what makes good therapy. And he's saying it's sort of three pathways. It's the relationship, it's the client's expectancy around therapy, and it's that therapy also ultimately gets people doing healthy things. These are the things that account for therapy is effective.
This is from his paper, How Important Are the Common Factors in Psychotherapy? An update by Wampold in October 2015. We'll have some of the resources on our page.
Absolutely. Yeah. So that sort of sets the tone for this debate. We can see where Bruce Wompold is situated in the great psychotherapy debate. He's part of the common factors school of thought. He's sort of connected to these, again, general, non-specific pathways to change. And that's sort of what he's promoting. That's what he's all about. When he's out there in the debate, he's saying, guys, and girls, it's not about, this or that specific factor or this or that specific piece of your modality. I've done the research. This is what the research is showing. It's showing we can really condense it down to these three different pathways. And so what does it mean for psychotherapy if we make it about these three pathways, the relationship and health promotion? And then in comes Jonathan Shedler.
Heavyweight in the corner.
So Shedler's sort of entering the debate from a different angle, whereas Bruce Wompold is saying, oh yeah, no, I'm going to draw my conclusions from this research. I have sort of good faith assumptions about this research. I'm sort of in agreement with the meta theory of this research. Shedler comes in and says, no, I think this research is actually bullshit. I think that I can't even agree with the conclusions or anything you're saying, Bruce, because I think the starting place that we're coming from is problematic. I think how we do psychotherapy research is problematic to begin with.
I love what you put here, and that was pretty close to what Jonathan was saying, is what is being researched can barely even be characterized as therapy. Yeah. It's like some type of manualized hodgepodge or witch's brew. I don't know, but can't be characterized as real therapy.
Yeah. I think so. I'll kind of get personal here. I think it was sort of like if I was the one of Richard and I to discover Jonathan Shedler, and Shedler came to me sort of at the beginning of my practicum, and at a time that was really important, actually, because I was really starting to practice and I was formulating my sort of core assumptions about how I wanted to do therapy. And what it was for me was I I had been in therapy before going to counseling school, and I'd been in a long form psychodynamic therapy for about 5 years, not weekly, mind you, but I'd been working with a psychodynamic therapist for years and years. And I'd had a specific type of experience in therapy, which was dynamic. So I was sort of carrying that implicitly into my training, my research, my schooling. And I experienced a disjunction between what I had experienced in my own therapy implicitly and what was kind of being taught in my schooling, right? About how psychotherapy is and what it does. And I couldn't really get over the fact that on the one hand, there was, like Wampold and other researchers were saying, this idea of the dodo bird effect and effectiveness equivalency, and this sense that the modality that I had done my therapy in was sort of no more effective or was in some ways completely equivalent to any other modality. There was a disjunction between that and my, really incredible and interesting and diverse and kind of amazingly meaningful experience in therapy, and the fact that I really didn't see what I had experienced in any other modalities. I wasn't really connecting with some of the other modalities in the way that I was with the psychodynamic sort of position orientation. And so again, I'm being told that they're all the same, that at some level they're completely the same. And yet I had this tremendous sense of, no, what you're talking about right now is completely different than what I'm talking about. And I didn't know how to navigate that. And then I discovered Shedler. I think I was through the This Jungian Life podcast, because they had him on, and he talked about the effectiveness research of psychodynamic therapy. And more importantly, what he did was he critiqued the way that psychotherapy research is done. And yeah, Shedler takes a very strong position. He says that what is being researched isn't even therapy. And maybe we can break that down a little bit, Richard, sort of why he makes the case for that, right?
I'd love for you to talk a little bit more about that, and I'll jump in.
Sure. Well, I think point number one he makes is that most psychotherapy research is based off of psychotherapy processes that last 8 to 16 sessions. And in his mind, that is too short. That is not therapy. In the podcast with Bruce Wompold, he sort of makes the case that any of the effectiveness that you're likely to see in 8 to 16 sessions is probably not due to any specific therapeutic mechanism or psychological change that's occurring. It's probably due to other effects. So certainly the expectancy effects that Wampold is a fan of and has built into his model, but also this idea of sort of remoralization. So something else that's sort of out there in the ether in the common factors space is this idea that what's more effective in therapy actually is that a patient becomes hopeful and becomes sort of remoralized, that most clients or patients come to therapy feeling a sense of hopelessness and like they can't get anywhere with their problem. And maybe it's not actually that therapies solve problems, but just that they imbue people with a sense of hope again. And that's sort of how they're effective, right? And so Shedler's making the case, probably when you see any type of effectiveness in 8 to 16 sessions, it's due to a remoralization effect, an expectancy effect. He referenced research that shows that for depressed patients, even just picking up the phone and making a call and booking a session has a positive effect, without even going to a therapy session, just initiating something has effect. So he's saying that these are what's operative, these specific mechanisms, but that nothing really psychological has happened. Nothing really therapeutic has happened in 8 to 16 sessions. And he argues that it wouldn't happen in 8 to 16 sessions. And he references research showing that regardless of modality, that it takes something like 6 months to a year at least to see any type of substantive psychological change in therapy. So his first critique is most psychology research is not even reaching the threshold of being of sort of a time frame of real psychological change. So how can we base our evaluation of what's good therapy off of something that isn't even getting to that very basic marker?
So essentially, it's like a temporary boost in motivation, perhaps
it could be a lot of things. He had some interesting language around it. I don't remember the specifics of it, but it was basically what's happening is there probably is some sort of positive effect to 8 to 16 sessions, but it's not a deep psychological effect, or it doesn't promote any lasting psychological change for someone.
Yeah, because that's been the obsession, because all of this is built off of the DSM model developed by managed health, the medicalization of psychotherapy, of symptom reductions. He talks a lot about, I think that's a key question, is because the person has reduced several points on let's say, the Beck depression inventory, is that really real lasting psychological change? And it would seem that Wampold and his camp in common factors would say, yes. They would say, well, maybe we would like to follow up. I'll give you this, Jonathan, that we should follow up longer. It's great when we can look at the person, at a year or longer. Often we don't have the money or grants don't allow for that kind of piece. But yeah, there's a reduction in symptoms. Maybe the person no longer meets criteria for a major depressive disorder. Yay, let's clap and let's go home, or therapy is effective and we can all pat ourselves on the back.
Yeah. You're sort of alluding to Shedler's second criticism, which is around how we assess outcomes. And I think we're going to talk on that too. But I love it. Like, they're just self-assessment scales. They're not measuring anything concrete or real, right? They're just measuring patients' assessments of themselves. A patient's assessment of themselves after 8 to 16 sessions of therapy can look the same as a patient's assessment of themselves after 6 months to a year of therapy, but be for different reasons, right?
Well
yeah,
said.
I can feel better after 8 to 16 sessions of therapy because I liked my therapist and because I'm just happy to participate in this study. And, I was feeling crappy and now I have someone to talk to, and that's helpful. Or, I just sort of have faith that this is going to happen. Like, I want to give some credit to Wampold for identifying expectancy effects because he's not wrong, I don't think. People believing in therapy working is essential, right? But is anything actually happening? Right. And Shedler would say, no, like it takes 6 months to a year, probably a year to 2 years in a lot of cases for people to experience last. And I want to break that down between you and I, Richard, because we're both with some experience now. Like, what are your thoughts on that? Because my thought is that makes a lot of sense. Like, I work in an environment where there's more of a short time frame that's expected, which I find myself conflicted around a lot, because what I'm really seeing more and more is that when I get to 10 sessions with a patient, often just getting to know them and maybe something of what's really important to them and relevant to our time together. And I think that I sort of feel and understand this pressure to work very, very quickly. And it often doesn't match up with people's, real experience in therapy. I'm finding that, I think Shedler's not wrong. 6 months to a year is, you're just getting going for sure. What about you?
Yeah, I've been thinking about it. I can see some elements of truth that I think both Shedler and Wampold are hitting on. I think it would be hard to argue that longer time in therapy where you actually are, first of all, you've built the relationship deeper, I think, but it certainly goes beyond that in psychodynamic therapy where you're actually looking into the attachments, how people view their world, their view of themselves and their view of their world. And we know that in attachment research that basically a person's attachment style, for example, is more predictive than a lot of other personality factors. It perhaps is one of the most predictive things that we can know about a person, right? So if a person has an insecure attachment, this can tell us more accurately how they'll behave in a lot of situations, a lot of social situations, relational situations, issues around vulnerability, etc. And certainly in psychodynamic, diving into the elements of how that was formed, the ruptures that happened, all of that, and then how that's carried out in the present. So in the sense, going back into the past and going slow to help deal with how the person sees the entire world and themselves, it makes sense that that would have lasting change. I think that, where I would maybe argue Shedler's, I think, of course, longer is great when we can, because we have more opportunity for deeper, longer lasting change. Of course, in our world today, we just sometimes simply do not have that time as much as we are arguing for accessible long-term therapy models. But I think if we hit on elements that go beyond certainly the contextual model or this idea that all therapies are the same, and we hit on some really, I think those things that are quite deeply rooted within psychodynamics that are the root causes of symptoms, it may not take even 6 months to see changes. I can see when I combine, for example, EMDR with a kind of a developmental attachment, kind of psychodynamic and somatic based approach of EMDR that with clients, we can see some significant change. And even when I'm following up with them several years later, they're saying that this is one of the deepest and most profound experiences. And because it's hitting on some core scripts, right? About who they are, how the world works, how they are in relationships. And, I am a huge fan of a psychodynamic model as much as, it seems very antithetical to the world today where like, oh, we don't even go into the client's trauma or like, don't go into the past. Let's give them some immediate symptom relief and let's focus on actions they can take today. And I think both for, as we've talked about before, both for clients and therapists, that feels really nice to be able to do that. That's the easy route. That feels really nice. But there is a panacea perhaps with that.
I think I'm sort of getting what you're saying, Richard, that you're saying sometimes you work a little bit faster than Shedler's sort of recommended time frame, which makes sense. And I've seen that too. There's been times where I've been able to support patients with something quite significant in a shorter period of time. But what I think Shedler's saying, and this is sort of what I get the sense that you would agree with this, and if you really don't, let me know, because then we can talk about it more. But I think what he's saying is that most people out in the field are not practicing in 8 to 16 sessions, and they're not practicing in kind of a manualized, heavily structured fashion. When we look at the way that real therapists operate, most of them, if the client expresses an interest in continuing therapy past an 8 to 16 week, sort of format, and their assessment suggests there's some benefit to that they would keep doing that, right? And that it's sort of unrealistic to assume that we should base our foundational assumptions about the effectiveness of therapy on therapies that solely operate within 8 to 16 sessions.
Yeah, I think in private settings, or if clients have good insurance, that is true. Again, certainly, I think I am a fan of more sessions, right? Especially if we are hitting on the root causes and we are really building the relationship. I am a big fan of the psychodynamic approach and attachment-oriented approaches and trauma-informed approaches. Yeah, and at the same time, we're very limited,
I think an interesting point that Shedler made in a different talk, which I really like and sort of hammered home this point, I think, is he sort of said patients say different things in therapy at the 6-month mark or the year-long mark than they would say the 8 or 16-week mark, that there's sort of a qualitative difference in the content and the focus of sessions. And an important one, when there's an opportunity for sort of a long-term process. And I think that's really interesting.
I would agree with that.
Because he's saying maybe by confining ourselves to 8 to 16 sessions, that we're actually stultifying opportunities in therapy because people don't have what they need in order to start to talk about or express or explore things that are really important and essential. So
I think that often is the case. Yeah.
So I think there's something to be said here. I'm hearing you, and I think it's fair to sort of push to the other side, which is, well, sort of multifactorial, actually, now that I think about it, why there's an emphasis on therapy being shorter, and not all of those factors are positive ones. So that's sort of a separate discussion that we should have. But I was going to say something like, we do want to be as efficient as possible. And I am in agreement with that. Despite my...
Yeah, as a supervisor, I can see that. And I think this is a problem, very well said, multifactorial. You have graduate programs that focus on giving a basic understanding of kind of micro skills and some of the common factors, and certainly client-centered. And by the end of the graduate program, they might be moving towards a particular school or have a few schools, right? Integrative, and using some advanced interventions, beginning to dip their toes in, but it's still very cursory. It's still very surface level. And I think the effectiveness is very limited based on that right away, right? Versus having and I've seen other colleagues argue for this too. And some programs you mentioned, McGill earlier on, of could we have a piece in the graduate program that is kind of a psychodynamic intensive stream for a bit, right? Maybe we have another stream, an existential stream or whatever, right? CBCT stream, but different streams where we immerse ourselves in this. So I see sometimes it's some of that structure and some of that support is really lacking. And I can see whether it's an experienced therapist, but certainly therapists that don't have as strong of a theoretical basis, I think in a depth focused model will be, we joke as supervisors to say that they take the shotgun approach. So they're going a whole bunch of different directions. There really isn't super clear treatment goals. There isn't maybe a really deep understanding of what therapy really is. And I would agree with many of the facets of what Jonathan Shedler would say about what real therapy really is. And so longer isn't necessarily better. And I don't think Shedler would necessarily would say, well, it's the right kind of long, right? It's working
That's right.
smarter in a structured way over a period of time that lets us get to where the client needs to be, or get the client to where they need to be.
I think Shedler is just making the case that there ought to be sufficient room, a sufficient time frame. Yeah. That it's not that therapy needs to go on forever, but that we need to provide this 1 to 2 year window for patients because his argument is that's what most patients need in order for real effective psychological change to happen. And that would include that sort of 1 to 2 year framework would include patients on the more severe end of, of pain, of psychological pain and suffering, people who struggle more tremendously. Shedler still has some confidence that within 2 years that, meaningful change could occur. Right. So, and he's just making the case that 8-16 sessions isn't enough. And he pointed out, for instance, that one of the databases in which many of the meta-analytical studies that people like Wampold and other common factors researchers and researchers involved in this great psychotherapy debate are sort of basing their assumptions on, this database. I forget the name of the researcher that sort of holds it, but it's publicly available. But you can look at the studies. There's a massive number of studies in it. The vast majority of them are studies that are looking at in-session, sort of research programs, right? So all of the assumptions that are being drawn and being thrown about in this great psychotherapy debate are being drawn from therapy that doesn't even resemble the kind of therapy that could make lasting psychological change, right? Of course, you're going to see some degree of equivalency when people only have 8 to 16 sessions to experience anything, right?
Yes.
We might say that rather than looking at all therapies being equally effective, that all therapies are equally ineffective in an 8 to 16 session.
Ouch.
That's what we're seeing, right? We're seeing all therapies not work the same way, right? Because they're not given a chance to at the 8 to 16 session.
Yeah, but we can see that in addictions as well, that a lot of reasons why people are relapsing, because that's kind of like such an extreme issue that people experience. And people that have, I think, both therapists and people that have struggled with addictions, they talk about that you are still very fresh in that 1 year of recovery, right? But we have this idea, even with fairly profound mental health issues, that, oh yeah, like 8 to 16 sessions, you're not depressed anymore. Right. The amount of rewiring that needs to happen in the brain and the lifestyle changes and all those things that support that maintenance of this new way of living need to be there.
Absolutely, right? That's such an interesting contradiction, that we sort of understand one problem needing a lot of time, but not another. That there's this prevailing assumption now, probably based off of the early research of CBT that showed, oh yeah, we can create some type of change in 8 to 16 sessions. That depression is a simple problem. It's amenable to a short therapeutic process, and that's enough for effectiveness to occur, which is, Shedler will argue not the case. And so maybe we'll move to his second line of argument now. This one he doesn't necessarily belabor, but it's implicit in the psychodynamic orientation. And I think it's implicit in what he's saying, which is that there's sort of this problem with manualizing therapies, which I can appreciate from a research perspective, is important. It's important to try to create consistency across the treatment that you're delivering. But Shedler would argue that creating that consistency sort of destroys the creativity that makes therapy essential, that ultimately you can't really create a one-size-fits-all therapy for every patient, that every patient's, sort of the process of therapy for every patient is unique. What people need to experience and the specific nature of their problems that need to work through is unique to each person. And so there's also a problem in kind of manualizing therapies and in prescribing or standardizing processes, in that something essential is lost or destroyed in that process. And again, I can appreciate the value, or in some ways the need, at least within this particular research paradigm that we operate in, sort of a logic to it. It makes sense that we try to standardize our treatments as much as we can. But I think Shedler would argue that something essential becomes lost in that, because therapy, again, as it's practiced in the real world, it doesn't look the same every time, right?
No.
And again, I'm kind of curious to get your thoughts on this, Richard, because
Yeah, I have some thoughts on it right away. I would say that they're trying to fit, research is a wide word, but we have associated the word research with RCT, with randomized clinical trial. Mm-hmm. So they're trying to fit the therapy into a model, into the medical model, which is considered the gold standard for symptom reduction, let's say, of a headache, anything from a headache to trying a surgical intervention, et cetera, of the designing a new drug, et cetera, to the randomized clinical trial. That's only one way of doing research, right? We have now put RCTs above everything else, and we're starting to see, experienced researchers, especially very community-oriented researchers I think that are thinking in systems and are working in complex systems with complex populations, are seeing that even when there's something like CBT that has now been tailored, let's say, for a particular population or has become more cross-cultural, that there's some big limitations from it. Implementations in trying to get the clinicians to use it because it feels very stilted, right? And in the clients to engage in it because it's not really reflective of the real world enough. And so we have to expand our idea, and I'm sure Shedler would agree with that, of what research is. We are trying to fit into, and they talk about this in the States, right? The National Institute of Mental Health. It's not that different for Canada, Health Canada, which still sees Health Canada really not only as RCTs kind of like as the most important, but in many cases, really the only way that it would be approved for a grant to get the research done, which is very sad and fucked up, to be honest.
Yeah, no, for sure. This is the only way that you're saying that this is what's understood. This is the only way to determine effectiveness in psychotherapy. I understand the logic of randomized controlled trials. I understand we would recognize them as effective, sort of from a scientific perspective, but I would sort of agree with you. Their applicableness in the space of evaluating psychotherapy is suspect. It's questionable, right? By rendering the therapeutic process sort of amenable to analysis under a randomized controlled trial, we kind of destroy it in a way, right? We change it. We turn it into something that it's not in the real world, because in the real world, therapy is messy. This is my experience, at least. All of my therapy
and clients
is so
coming
messy.
in have complex lives, right? Yeah. So we also in RCT, we exclude so many people. So there's an access issue. We can see that right now in psychedelic psychotherapy, where what is Health Canada saying to people that are suffering from suicidal thinking because of like cluster migraine headaches that are intolerable. And we know that, for example, psilocybin is quite effective, and even Health Canada acknowledges that, but they will not. This was just in the news right now. Therapsil was talking about this, and the particular patient was putting their name out there and talking about this. That person is going to remain in suffering and potentially may not stay around in the world that much longer, or certainly put themselves potentially at risk by, they're forced to find underground means instead of recognizing that it's a human right to access an effective treatment, right? So they're told, let's say, for example, by Health Canada, the only way you can access this is a randomized clinical trial. And because of their issues, because there's very few numbers of clinical trials on that particular issue, and just even getting into an RCT, they by nature are exclusionary, right? Mm-hmm. They are really geared towards people that let's look at clinical trials, are white, college age, or professionals. They have to have sufficient income. They have to have sufficient ability to fill out kind of all of the measures and all of the paperwork. They also have to subscribe to a very strict process. So a client who is coming in from another country, they're discriminated against, they're, let's say, an LGBTQ identifying Muslim with complex PTSD, how are they going to get into a type of trial for almost anything, right? There is some changes in that area, but a lot of other forms of research are more amenable to complex issues, such as very well-structured case studies. And there's an argument that having a sufficient number of case studies equals the level of rigor or robustness or strength of an RCT. So yeah, we're very, very constrained in these structures. And so, yeah, it's kind of like we're forced to put psychotherapy into this happy meal model.
Yeah. Well, I sort of want to keep it at the level of our personal experience here, because mine is that every client I meet is different. I don't think I would know how to standardize my treatment, even though the problem that I work with is sort of a standard one. I work in psychosocial oncology. All of my patients have cancer or are family members of patients with cancer. I find that with every patient, I sort of have to ask the same dumb question, which is, what makes cancer hard for you? Because there isn't a standard understanding. And in asking that question, it's a lovely question because everyone has a different answer, right?
Yes.
I know that cancer is hard for a lot of people, but why cancer is hard for a lot of people is very different. And the diversity of conflicts and sort of vulnerabilities that we have to address in order to help the person psychologically function well in regards to their diagnosis is vast, and it's as wide as the number of patients I see. So I really feel akin to Shedler in this regard, that we have to leave a degree of openness and flexibility in our approach to therapy in order to meet people where they're at. If we prescribe the same therapeutic process for every single person, we're destroying the creative opportunities that are essential to good therapy. And if Shedler's not arguing that, I am. That's my argument.
And this is why I really like process research, because you can study therapy, in vivo kind of as it happens, or other forms of research. So I love that, what you're saying too, right? You have psychotherapy in the wild, and that truly is the case. And can our methods for studying it reflect that too?
For sure. And so again, Shedler's saying we're not really studying therapy because we're studying randomized controlled trials, and those kind of destroy therapy, or they structure or they create a kind of therapy that doesn't exist in the real world and that isn't practiced in the world, right? So that's sort of line number 2. And then line number 3 of attack, as you alluded to earlier, the way that we evaluate outcome is problematic. We tend to focus on, first of all, we tend to define our understanding of people's problems in terms of diagnoses in the DSM. And there's massive problems with codifying and sort of defining like problems that we experience in the context of disorders. Shedler and I imagine you too, would argue that disorders don't really exist, that disorders are just a set of characteristics that people demonstrate. They don't actually speak to a real sort of ontologically real entity operating within a person. There's, I think, within depression research, for instance, there isn't necessarily a singular disease process that operates in everyone that has depression, right? We might say there's no such thing as a depressive disorder, just depressed people. And Shedler makes the case that he uses this lovely medical metaphor, which I absolutely love it because it kind of turns the medical model on its head. He sort of makes the case that the kind of presenting symptoms that tend to bring people to therapy, depression and anxiety, these are non-specific symptoms. These are the equivalent psychologically to something like a fever, right? And if you're a practicing physician, when someone has a fever, it's not obvious what causes a fever. There can be thousands of different reasons that a fever, someone's experiencing fever, right? All that a fever tells you is that there's something going on that warrants attention, right? That we have to go searching and assess and try to find the discrete cause of the fever. And it would be the same for depression or anxiety. Depression or anxiety are just a sign that a person is facing a problem, but they're not the problem in and of themselves.
Well said. Yes.
But the way that we practice psychotherapy today, we treat depression and anxiety as though they are the problem that the person is facing.
Oh, they are depression, and
without looking at what sort of drives or propels the depression in the first place. And what makes it necessary or brings it into the person's experience, or what about the person makes them vulnerable to that kind of experience, right? Shedler would say what's more important is to sort of go to the psychological substrate that precipitates this problem and to work there. And he makes a really great comparison when talking to Wampold about This is important from a research perspective. He says if you take a person, for instance, or you take a group of people that are experiencing fever, and then let's say it's fever due to an infection, you give them a fever reducer like a Tylenol or an aspirin or something like that. You give them an antibiotic treatment, and then you assess over a relatively short time frame, let's say a few hours or something like that, who's got a fever still. The Tylenol is going to come out looking hot.
Yeah.
Whoa, look at this Tylenol.
Amazing.
It's so good. Yeah, that's right. Whereas if you were to, again, hold the time frame over a certain period of time, the antibiotic would be the clear winner, right?
Yeah, and maybe the people that took Tylenol aren't around anymore, unfortunately.
And that speaks to two things. And again, it makes the case for the too short of a time frame, right? And the problems with relapse. And it also makes the case that, like if we're not sort of structuring our therapy around what precipitates or creates these problems to begin with, if our therapy is just about ameliorating symptoms associated with the problem, then we're not really doing therapy. That's sort of Shedler's third argument.
We're giving people a psychological equivalent of a Band-Aid or a Tylenol versus the antibiotic or antiviral.
That's right. But we're assessing therapy as though this is what therapy is and is about, right? If you look at the studies that these meta-analyses are based off of, almost all of them are about therapies that have some effect on DSM disorders. So there's an operative assumption in this at first, which is that what we're treating is disorders. And there's a whole bunch of modalities that would disagree even with that basic conceptualization of human suffering, that would say, no, we don't treat disorders. We treat existential challenges. We treat psychological conflicts. We treat trauma, right? It's not disorders that we treat. Yet, when we evaluate psychotherapy effectiveness, we evaluate how effective it is at treating a symptom or a sign of a problem rather than the problem itself.
I love how you sum that up.
Thank you. What are your thoughts?
Oh my gosh, I'm almost at a loss for words because you summed that up so well. It's a good problem to have.
Well, sure, I'll take the win on that.
Please.
Sure, thanks. Yeah. Okay, then the fourth line of attack.
Okay.
Shedler says we need to follow people longer than we do. So sort of connected to the way that we assess outcomes, it's not only that we can't just look at how outcomes, and sorry, we maybe didn't say enough about outcomes now that I think about it, because one of the things that I want to say, and when you talked about randomized controlled trials, you were alluding to this all over the place, that how we measure outcome is important too. If we're only looking at a reduction in the symptoms associated with a DSM disorder, we're not always capturing the significance or the meaning or the value of the therapy for the patient, the person actually experiencing it. You've talked about case study research, and I'm interested in like qualitative assessment or qualitative measures of like psychotherapy effectiveness as well, because I think that, we're doing therapy with people. And I think that ultimately patients are the best, or at least an important component of how we assess effectiveness. Why do we always just focus on the reduction in these sort of characteristics rather than looking at, patients' own conceptualizations of what's changed or what's gotten better through the therapy? Because I think that patients in their own endogenous language often can tell us more about what really happens in therapy if we're willing to listen to them.
That's the important element of qualitative research. And I am happy to see that I think there is shifts in that, in the field, that people are understanding, even quite strict quantitative researchers, of, having a qualitative element of hearing what the participants have to say is important, because it actually helps us understand why we have the results that we do or why we don't. And it alludes to mechanisms and perhaps root causes, but certainly mechanisms of what might be happening to induce the change, or again, when the change doesn't happen, right? Barriers to treatment.
Yeah, there's a missing element, which is the human element. When we only look at outcome measures, let alone that, Shedler makes the point, like when we assess psychological change in a person, is a modest reduction on the Beck's depression inventory really a good assessment of whether or not something significant has happened in terms of change for someone? Or
is that our ultimate goal in life and for a client's life? I don't know if he alluded it to, I can't remember, but we talked about this in our earlier episode about kind of symptom reduction versus healing transformation. Really, like, how sad is that? Like, all that, so many billions of dollars in trials have been focused on getting a reduction of a few points on, let's say, a depression inventory or an anxiety inventory. And okay, so the person is now no longer meeting the clinical criteria for depression, let's say, like that's it. Like, what about their functioning? Right. So, and maybe we might go and do something, like in the DSM-4 that had the GAF, the generalized, assessment of functioning, where, we're saying, oh, their GAF score went up from 30 to 50. But again, those are really like, that's maybe 3 or 4 sentences on each description of the GAF of, well, do they actually connect with their children better? Are they actually happy about life? Are they actually closer to understanding what their calling is? Do they understand how they work and how other people work and what their core values are? Nothing like Abraham Maslow and looking at, peak experiences and whether they're reaching their full potential. And positive psychology is looking a bit more on this. Transpersonal psychology, it doesn't touch on any of that. What a short shrift we're giving our clients by over focusing on the symptom reduction in RCT.
Well said.
There's my rant.
No, I love it. A nice piece in Jonathan Shedler's case for why we're not really researching therapy. What we're most concerned about is just sort of surface change or small change, when our ambitions about what therapy can be don't match the ambitions that a lot of therapists have about what therapy ought to be, right? I mean, I'm with you, Richard, in that, like, when I sit with my patients, I'm not looking just for like, okay, can you be a little bit less depressed today? I want to help them profoundly shift their sort of psychological position in relation to their cancer to one that allows them to live better with this huge and tremendously difficult life transition that they're going through, right? That's a tall order. That takes a lot of ambition on my part. I'm creating a big enough space in our therapeutic room for whatever needs to happen in order to get it, for us to get there, right? Mm-hmm. And yeah, I mean, I don't even know how I would evaluate the outcome of my process with a lot of my patients, but it certainly wouldn't be on scores on the Beck's depression inventory or some other.
Actually listening to
that's right.
Our clients for once and hearing what they have to say, and then letting that guide our treatment.
That's right. Yeah. So I'm generally in agreement with Shedler too, that, we need to think differently about how we actually evaluate what is effective psychotherapy, right? We need to kind of go back to the drawing board in that.
Yes.
Yeah. So his next is sort of the fourth line of attack is just also the way that we assess outcome needs to change in terms of time frame, that we look at too short of a time frame for establishing or evaluating effectiveness. Follow-up tends to be in the realm of 6 months to 2 years, like in terms of looking at long-term effectiveness of treatment. And Shedler argues that, okay, maybe 2 years, but he's really looking at, why not go longer? Why not look at the really long-lasting implications of
like longitudinal studies?
Yeah. Exactly, yeah. Am I really concerned about how a person's going to be doing even, say, 2 years after a therapy? What about 5 or 10 years after a therapy, right? That, that we're maybe not ambitious enough in terms of how we think about the kind of change that we can create in therapy. Because I think Shedler's experience is that the kind of lasting effect can be profound. He's a big part of contemporary psychodynamic effectiveness research. One of the things that he highlights in his article of Psychodynamics of effect size of psychodynamic psychotherapies, which first of all is actually kind of bigger than a lot of other therapies. So that's interesting. So he's saying that psychodynamic psychotherapy exerts more of an effect relative to other therapy modalities, but also that its effect size grows over time.
Oh.
So what he sees is that as time goes on, because they've engaged in longer term follow-up in some of their research studies, the effect size continues to increase, whereas for other therapies, it stays the same or it decreases. So his interpretation of that is we're not just dealing with sort of a discrete, sort of specific problem. We're helping people in a way where they continue to get better long after we're out of their lives and the therapy is ended.
Beautiful.
Shedler is making the case that there are maybe effects associated with therapy that we can't even see because we don't look far enough. And that needs to be an important part of our evaluation too, that the time frame of assessing effectiveness needs to be long enough to appreciate the full effects that therapy can bring about.
Because as you said before, clients and maybe therapists as well are seeing and saying qualitatively different, very different things 6 months, a year, 2 years plus, right? Whereas most RCTs and 6 months, even after follow-up, maybe a year at the very most, that would reveal some of these deeper mechanisms that are key to, as we've talked about, healing transformation.
The final point is one that him and Bruce Wompold kind of agreed upon. It was interesting to watch Wampold in this debate because
maybe one of the few things they agree on.
Because I think Jonathan Shedler's position is so outside of the contextual model because it's critical of the very foundations of the contextual model. The contextual model is sort of saying, through the research data, we've discovered these non-specific pathways to change and psychotherapy effectiveness. And Shedler's saying, well, actually, the research basis sucks. Actually, if we did research, it would look like psychodynamic therapy would probably stand out. That's a pretty controversial and intense thing to say, right? And I think Wampold struggled with that. But one of the things that they did agree on was that the way that our contemporary research paradigm works right now is that certain heavily researched therapies get represented as the gold standard of therapy, and they get offered as effective without appreciating everything else that Jonathan Shedler just said, his whole critical analysis of the psychotherapy. In the efficacy of psychodynamic psychotherapy, I believe he does engage in a critical analysis of research in other modalities. And he points out, quite rightly, referencing specific research studies, that if you really break down the numbers, the vast majority of people actually don't get better in some of these shorter term manualized structured treatments. That the numbers might indicate some degree of change. It's often a small one. And in some studies, it actually shows no benefit at all. The people drop out before they actually participate in the study, or they participate and there's no effect. Maybe for 50% of the people there's effect, but for 50%.
Yes, he referenced the APA paper, which did a meta review of, I think it was hundreds of studies on depression, on RCT, manualized based treatments for depression, and finding that kind of shockingly and abysmally, maybe not to us, but to perhaps the stakeholders or the funders of the research, that, something like only 50% of people improved, and the improvements that they made were relatively minor and short lasting.
That's right. And something like 25% of the people that did improve didn't improve very much or for very long. The effects diminished over time. So you could say they didn't really improve at all ultimately.
And a certain percentage got worse.
Yeah. Here we are espousing certain therapies as the most effective, the gold standard of treatment. And in a lot of cases, this is the only therapy that people are being offered. They're accessing healthcare systems, they're accessing mental health care systems. They're being told that these therapies are effective. They don't have access to or an understanding of the critical research around psychotherapy evaluation. And they're also not being given multiple options. So they participate in the therapy thinking that it's the best. It doesn't work for them. And Shedler's case is then they don't go and turn around and go, okay, well, I guess that therapy wasn't effective. They turn around and they go, oh, I guess my problem is so bad that I'm beyond help.
That's unfortunately what they're left with, yes.
Yeah. And both Shedler and Wampold agreed there isn't enough choice and there isn't enough informed consent in our present day systems, that our systems tend to focus on what is expeditious and convenient to them and often advertise therapies as the best without allowing people to sort of critically evaluate what is available and what could be available to them. And people are rarely offered long-term options, at least in a public health sphere.
And I loved what Shedler said, which is so controversial, but would be actually matching with an ethical understanding of informed consent, because even the CRPO in Ontario is really reinforcing that when we use let's say when we're switching a client from, let's say, CBT to psychodynamic, that we get their consent about a switch of treatment modalities. But Jonathan Shedler is going way beyond that. He's saying what we should be doing is informing clients from the start is that we have this thing that's maybe kind of therapy-ish, therapy, like some type of
Could help.
modified replicant hybrid. I
Yeah.
don't know.
Could help. Could help. Yeah.
It could help, right? There's a certain percentage that it might help. It might help for a while, right? And so there are some benefits there, and there's also some really big limitations. And because we're kind of confined, maybe in our particular healthcare space, I can think about when I worked in employee family assistance program, only a few sessions at a time, then having to seek reapproval, and then sometimes still maximum, let's say 6 sessions, maybe for a year that clients would get for free. Being honest about like, this is kind of what we have. It can do, perhaps it might do something for you, but there's a chance too that it might not really address your problem and that might actually not improve. It might not improve things for you. Doing this would then not like destroy in the client's mind that either all therapy sucks or I suck as a therapist, or I suck as the individual client. And it might, as you said, my problems are just too big, and would leave the client with, okay, well, I tried this. I knew and was told what I was trying, and was also offered perhaps like, okay, if you're looking for longer term therapy and based on your issues, perhaps, following up with this therapist that is doing psychodynamic type work, or, you might want to look at these types of therapies that are longer term and focused on some of these factors that might be more related to long-term lasting change and insight, right? We don't do anything like that.
No, we don't allow people to evaluate options and choose from a range of therapeutic services. Island Health, which is where I live, or they go to Fraser Health, which is where you live.
Child provincial mental health.
Exactly, a provincial health authority, and they ask for support. They're offered short-term behavior-based, either CBT, DBT, ACT modalities, and that's
Maybe
it.
if they're very lucky, they'll add a little bit of mindfulness, sprinkle a little bit.
Yeah. But they, and that's because it's convenient to the system. It allows many patients to be served in an expedient fashion, but it's not necessarily what's best for people. If we take these criticisms seriously, then that becomes obvious, right? Jonathan Shedler is making a case here, a case for broad problems in the way that research is evaluated. There's a sort of another point that I want to bring up before we end this episode tonight, Richard, because one of the things that I felt that Jonathan Shedler didn't do is he sort of pulled his punches. He maybe didn't shoot far enough. There was sort of a point where him and Wampold were talking about the relative effectiveness of, say, behavior-based therapies or something like that. And this is me reading into it. So I want to preface this by saying that I don't think I know what's in Jonathan Shedler's mind. I just know what's in my mind. This is what I thought about it. But my sense was that Jonathan Shedler sort of went, yeah, well, I guess we need both. But I don't know if he actually believed that. And, Wampold did sort of challenge Jonathan Shedler. He sort of said, yeah, and so what if you have a patient that sort of doesn't want to engage in the arduous task, which is psychodynamic psychotherapy? What if they just want skills? And he even made the point, which I thought was really interesting, that Jonathan Shedler was talking about how a lot of patients he sees, they've come from other therapy modalities and haven't found them effective. And they're so happy to finally meet a therapist that will really work with them in a depth-oriented way and, really get to the heart of their real problems. And Bruce Wompold said, what's funny is I've heard the same thing from cognitive behavioral therapists. They get clients that have come from a psychodynamic process 2 or 3 years, felt like they didn't get anywhere, and they're so happy to just be able to get some skills. And so, it's sort of interesting because on the one hand, Shedler is quite critical of this sort of idea of equivalence. He's really, in a way, kind of trying to break the whole system down and get us to start from scratch. This problem of equivalence is only a problem because of the way that we do therapy research. If we did therapy research differently, we'd probably come to different conclusions. And yet he sort of then kind of softballs Wampold and goes, yeah, well, I guess we need both. We need diversity. And so I sort of want to end with this thought. Do we need diversity? Is there a case to be made for just psychodynamic psychotherapy? And what does it mean if a client sort of looks at that and doesn't want it? Or what does it mean that clients have an interest in, or sort of that's what they ask for? Because my thoughts on that are mixed and controversial. How much of this is an expression of a real need for diversity in approach, and how much of this is an expression of a need for understanding psychodynamics and defense and the kind of vulnerability that patients come to, and more just the need to structure our process in a way that feels safe to patients. We sort of assume that for some patients, CBT is necessary or essential or preferred, and we just take that at face value. We just assume that the reason is that people are just different, or again, we have this sort of idea of equivalency, different strokes, different folks, right? But if I'm consistent with Shedler's argument that a psychodynamic frame is maybe a more effective one, could we not make the case that maybe there's a specific dynamic operant in patients that maybe don't like the idea of psychodynamic psychotherapy or don't find it immediately agreeable?
Mm-hmm. For myself, I would think about, maybe they're not ready for that, is the immediate thinking that I go to. And there perhaps is defense mechanisms or other, there might not be just defense mechanisms. There might be a number of environmental and other life barriers that are preventing their engagement in something so depth focused.
I'm thinking about my own experience with one of the first counselors that I ever went to, that we met for several sessions, that at some point he sort of invited me, look at my history more. There was a lot of pain in my history. There was a lot of difficulties. You're right, I didn't feel prepared. And I exited therapy. I walked out, and it wasn't his fault.
No.
He was inviting me in good faith to something that he knew would be helpful. I can sort of see the logic. Like, I walked away from that therapy and sort of went, believe it or not, Richard, there was a time where I went, I need cognitive behavior therapy. I need cognitive behavior or cognitive therapy. I need to just work at it at that level, right? And so part of why I speak in this way is because I have my own sense of my changing relationship to therapy. And it just took a successive number of experiences where I could have a therapeutic encounter that actually meant something for me to appreciate the value of the therapy. It wasn't obvious, though, initially. It wasn't obvious to me. It took time. And especially in this atmosphere of behavior-based therapies being privileged, I think it's hard to make the case for psychodynamic therapy, right? So all of this to say that I think that Shedler maybe pulled a couple punches there. He maybe could have gone further, and I don't know why he didn't, or maybe, I'm sure there was a reason.
Maybe he wants to keep the harmony of the relationship with Wampold.
Sure. Or, and maybe I'm just reading into it too much, but I wonder, could we not extend the conversation and go even further and say, well, maybe the reason that actually this therapy can reach everyone, like if we redesign our therapeutic paradigm and start from the ground up, and it suddenly does show a psychodynamic therapy as ultimately more effective, what does that say about therapy then, right? And are we doing a disservice by sort of play acting at believing that behavior therapy still has a place or is still effective in some way? I realize what I'm saying is extremely controversial, but...
Sure, but one thing I will say right away, I just finished the book Predictably Irrational by Dan Ariely, the famous behavioral economist, psychologist, and he talked about, he was burned on 70% of his body due to an accident, a flare affected him. And he was studying with his experience in the hospital of these bandages being ripped off. And then years later, as he's had a bit of healing, he went in to educate the nurses and do a bit of a study around why they pull off bandages fast versus slow, right? So why they're using basically a particular clinical intervention. And he found it actually had really nothing to do with how effective it was at preventing further damage or increasing healing. It was to prevent the nurse's own feelings of causing pain over a longer period of time. And that's why they did the quick kind of rip off of the bandage. And it supported this idea. People just kind of thought, well, this is what's best. And so I think we're in a similar place at psychotherapy and actually looking at a number of both psychotherapy and medical and other interventions. I had worked with, it was a great course on evaluations because that's my big focus is program development and evaluation, because you are asking a lot of these questions about why does something work? What are the barriers, that are preventing this program from working? Or it could be for therapy as well, for therapy working. And I remember a speaker saying the most dangerous phrase in the English language is, this is the way we've always done things.
Yeah, I love that example, Richard. And I sort of hear the resident implications in that. We need to look at this more. We need to look at why it's important to shorten psychotherapy to keep us out of difficult territory, to create useful models, to make psychotherapy about functioning. These are all dimensions of our critical evaluation that we often bring into our episodes. So I appreciate that and your alliance in this. I don't want to be unduly disparaging to a whole sort of sector of the therapeutic population, but I think there are essential discussions that aren't happening right now about psychotherapy effectiveness. And Shedler's sort of the front runner in that, right? Real deep problems associated with the behavioral paradigm that just aren't being discussed, right? And so maybe we'll have another episode where we look critically at that. But
One other thing is I think we're both big believers in clients' choice. And so sometimes people haven't felt, sadly enough, they haven't been through enough suffering or pain or understanding kind of the circumstances they're in to be ready for there to be a change, right? It's that idea of the pain of suffering, right, has to be more than the pain of, the time and effort it's going to take to change, right? So I think there's a lot of well-meaning clients, well-meaning therapists. Sometimes we do things, certainly we do things that it might be better for us. It might be better for our systems. That needs to be really looked at. And also we have to give choice to clients. I think the informed consent model that we talked about would really help with that. And to let clients even fail, to let them maybe be in suffering or let them try some different things, right? With, again, an educated guess and informed consent. And maybe they'll pick up some helpful things along the way as they try CBT, behavioral, but knowing that and telling them that actually there is, more to your philosophy than what's perhaps dreamt of in your current understanding.
Well said. Yeah. And so final thoughts and reflections. I think this is an interesting place. We started in the great psychotherapy debate with Jonathan Shedler sort of undercutting the whole thing. That it'll be interesting to do further episodes on this particular topic and see if our thinking changes at all, see if other voices in the space have different things to say. But I certainly think Jonathan Shedler has made a very strong case against contemporary psychotherapy research and a case for starting from the ground up again, for really deeply evaluating what we're doing. And so I hope our listeners took something from this as well, and as they evaluate their own practice and as they engage with the research.
And maybe if they have some questions, they can reach out to psychotherapywise@gmail.com and other means of reaching us as we launch on different platforms, because we'd love for them to weigh in and maybe jump in the ring with us.
Yeah, that would be great and very welcomed.
Yeah, even coming on, perhaps.
Sure, absolutely.
Thanks. This has been great. Yeah. I've loved boxing with you. Maybe we're on the same team boxing against poor Wampold there, but
Bruce.
We're all on the same team. We all want to help.
We all want to make therapy better.
We all want to make therapy better.
All right. Take care.
Take care. We hope you enjoyed the podcast and are a little wiser for it.
Thanks for listening.